As we conclude Module 6, we turn to one of the most challenging and most meaningful areas of communication in gerontological practice, engaging with older adults who are living with dementia. Dementia affects memory, language, executive function, and processing speed. As these abilities change, communication can become more difficult for both the individual and the caregiver or professional. When communication breaks down, frustration can emerge. Agitation may increase, isolation can deepen, and misunderstandings can escalate. But here is essential truth. Even when language changes, the need for connection does not disappear. In this lecture, we will explore best practices for communicating with older adults with dementia. Our goal is not necessarily to manage symptoms. It is to preserve dignity, foster understanding, and maintain meaningful connection.
You can have it. Pass it. I'll spend it in you.
To communicate effectively, we must first understand what changes. Remember, dementia is not a single condition. It is a syndrome caused by multiple underlying diseases. But across types, communication changes tend to follow certain patterns. In early stages of dementia, we may observe word-finding difficulty, mild repetition, trouble following complex or abstract instructions, and increased effort in conversation. Importantly, though, the social awareness of the patient is often preserved. Many individuals are acutely aware of their difficulties, which can lead to embarrassment or withdrawal. At this stage, supportive communication strategies can significantly reduce anxiety and preserve engagement. As dementia progresses, communication changes become more noticeable, and we may see that language becomes less organized, narrative coherence declines, multi-step instructions become difficult, and comprehension of abstract concepts weakens. Emotional reactivity also may increase. Individuals may become frustrated when they cannot find words or follow conversations. At this stage, simplicity and structure should become more central to the conversation. In later stages of dementia, verbal language may become minimal. Responses may be limited to short phrases or sounds, and comprehension may be significantly impaired. However, and this is critical, emotional responsiveness often remains. Individuals may respond to tone, facial expression, music, touch, and familiar routines long after verbal language declines. It's thus important to recognize our ability to communicate with someone with dementia does not evaporate. It just, shifts.
You can have it. Pass it.
Across all stages, several principles guide best practice. First, take a person-centered approach. Always focus on the individual, not the diagnosis. Use their preferred or chosen name. Reference familiar topics, relationships, and life experiences. Personal history can be a powerful bridge. Knowing someone's past profession, hobbies, or values can anchor conversation and reduce confusion. Remember, dementia does not erase identity. Second, simplify without infantilizing. Use short, clear sentences. Present one idea at a time. Avoid abstract language and metaphors that require higher-level reasoning, but do not adopt a childish tone. Remember how we mentioned elder speak in a few of our previous lectures? Patients with dementia can also recognize it and react negatively to these adjustments, so be sure to avoid childish tones and any oversimplification that strips away adult identity. The goal is clarity, not condescension. Third, and I can't stress this enough, slow down. Allow time for processing. After asking a question, pause. Silence may feel uncomfortable, but rushing can increase confusion and frustration. Processing speed often declines, but with time, meaningful responses are still possible. And fourth, be sure to validate emotion. This may be the most important principle. If a person insists they need to go to work when they have in fact been retired for several years, arguing about factual accuracy may escalate distress. Instead, respond to the emotion. It sounds like you're worried about something important. Tell me about your work. Validation acknowledges emotional reality, even when factual memory is impaired. Connection often matters more than correction.
You can pass it.
Let's now move into some more practical techniques to employ when speaking with an older adult with dementia. First, use structured questions. Open-ended questions like, "What would you like to do today?" may overwhelm someone in moderate stages of dementia. Instead, offer structured choices. Would you like tea or coffee? Would you like to sit here or over by the window? These preserve autonomy while reducing cognitive load. Second, rephrase rather than repeat. If a person does not understand something on the first go around, repeating the same sentence louder rarely helps. Instead, rephrase your statement. As an example, if you say, "You need to take your medication before breakfast," and the patient doesn't understand, try saying, "Let's take this pill now, before we eat." Third, avoid asking why questions. "Why did you do that?" requires abstract reasoning and can feel accusatory for anyone, including an older adult with dementia. Instead, ask, "What happened?" or "How are you feeling?" And finally, when necessary, redirect gently. If a conversation triggers distress or has the potential to trigger distress, redirect calmly. For example, if any older adult with dementia states, "I need to go pick up my children from school," correcting them outright might cause agitation or frustration. Instead of correcting them, you might say, "You were such a devoted parent. Tell me about your children." Redirection like this maintains dignity while reducing anxiety.
You can pass it.
As verbal ability declines, nonverbal communication becomes even more important. Here are a few tips to consider. Maintain warm eye contact. Smile when appropriate. Facial expression conveys safety and reassurance. Keep your tone calm and steady. Avoid sharp, abrupt changes in volume. Emotion is often transmitted through tone long after words lose clarity. Appropriate, culturally sensitive touch, such as holding a hand, can convey reassurance. Always observe how the individual responds and respect boundaries. Sit at eye level. Avoid looming over someone. Approach slowly and from the front to prevent startling. Now, these are all important things for us to employ, but what about the patient? In other words, are there things we should be looking for when they are attempting to communicate? Well, as it happens in dementia care, what are often labeled as behavioral symptoms are frequently forms of communication. Agitation may signal things like pain, fear, overstimulation, hunger, or even fatigue. Thus, if we are working with an older adult with dementia who is expressing behavioral symptoms, instead of asking, "How do we stop this behavior?" ask, "What is this person trying to communicate?" A helpful framework is the ABC model. A for antecedent. What happened before? B for behavior. What occurred? And C for consequence. What followed? Understanding triggers can reduce recurrence. In this way, behavior is actually a form of communication.
You can pass it.
Okay, at this point, we've covered several different tips and strategies to consider when communicating with dementia patients. And now, here are some more. When in a clinical setting, ensure hearing aids and glasses are available and functioning. Minimize background noise. Include caregivers appropriately. But continue addressing the patient directly when possible. And reinforce key information simply and consistently. In long-term care settings, maintain consistency in staff as this supports recognition and trust. Follow structured routines to reduce confusion, and incorporate familiar environmental cues which can improve orientation. And finally, in home care settings, educate caregivers about validation strategies, normalize caregiver frustration, and encourage respite and support networks. Caregiver burnout directly affects communication quality, and the more we support our caregivers, the better they'll be able to support their patients.
You can pass it.
Finally, communicating with individuals living with dementia raises important ethical questions. First, how do we preserve autonomy? Even as decision-making capacity changes, individuals often retain preferences. It's important to offer choices when possible. Avoid making unnecessary decisions on their behalf. There may be some patients who lose their ability to self-regulate, but we cannot assume that's the case for all dementia patients. Second, how do we navigate truth-telling versus therapeutic validation? In some situations, correcting factual inaccuracies may cause harm without benefit. We don't want to not tell our patients the truth, but the truth can lead to distress in some instances. Ethical communication requires balancing honesty with emotional well-being. The goal is not deception, it is minimizing distress while preserving dignity. Third, how do we modify our communication without accidentally engaging in elder speak? Even in advanced dementia, individuals deserve adult respect. Tone and language matter. Dementia does not erase adulthood. There is a balance to be made, and honestly, it takes some practice to get there. Finally, how do we best support caregivers? Caregivers are central communication partners. They may experience emotional strain, guilt, or frustration when working with their patient or loved one. Providing them with communication tools improves outcomes for both caregiver and person living with dementia. Training, support groups, and interdisciplinary collaboration, including speech-language pathologists and social workers, are essential. This lecture brings together many threads from the course. From Module 1, we learned that aging is heterogeneous. Dementia does not define the entirety of a person's aging experience. From Module 3, we explored cognitive changes. Dementia represents pathology, but emotional responsiveness often persists. From Module 4, we examined social context. Family dynamics and cultural norms shape dementia care. From Module 5, we emphasized cultural humility. Communication strategies must be culturally responsive. From earlier in this module, we established that communication is an ethical act. And so, to summarize the content of this lecture, communication remains possible at every stage of dementia. Even when words fade, emotion remains. Even when memory declines, dignity endures. Effective communication in dementia care requires simplicity without infantilization, emotional validation, nonverbal attunement, behavioral interpretation, and ethical awareness. As you reflect on this lecture, consider, how might shifting from correction to connection transform your approach to dementia care? This concludes the third and final lecture for Module 6. If you have any questions about the material covered in this lecture, please contact your instructor for this course. Thanks for watching.